Let's begin our advanced clinical review by exploring the pathogenesis of tuberculosis. When a calcified subpleural lung nodule is seen alongside a calcified hilar lymph node on a chest X-ray, this classic finding is known as the rank complex. It represents the healed calcified stage of the Ghon complex, which itself is the combination of the initial Ghon focus and the involved hilar lymph node. Sequence highlights the body's immune response to primary TB infection, where the infection is contained and eventually calcifies. Recognizing these radiological patterns is crucial for clinicians, as they often indicate prior exposure and healing rather than active disease. Understanding these stages sets the foundation for mastering TB diagnosis and management. Moving forward, let's discuss reactivation tuberculosis and its hallmark clinical features. Secondary or reactivation TB most commonly occurs in the apical and posterior segments of the lungs. This is because Mycobacterium tuberculosis thrives in areas with the highest oxygen tension, and the lung apices provide exactly that environment. Reactivation is often characterized by cavitation due to casating necrosis. Clinically, active pulmonary TB presents with a classic triad of symptoms: fever, night sweats, and weight loss. Fever is usually low-grade and tends to worsen in the evening, night sweats can be drenching, and weight loss is often significant and unintentional. Recognizing this triad is essential for early suspicion and diagnosis of active TB. Accurate diagnosis of tuberculosis relies on understanding both classic and modern testing methods. The unique cell wall component mycolic acids gives TB its acid-fast property and resistance to digestion by macrophages. For rapid diagnosis, the GeneXpert MTB-RIF test is recommended by the WHO as the initial test for suspected TB, providing results in less than 2 hours and detecting rifampicin-resistant. For latent TB, the tuberculin skin test (TST) uses different induration cutoffs based on risk factors, with a 5 cutoff for HIV-positive patients. The interferon gamma release assay (IGRA) is preferred in BCG-vaccinated individuals due to its higher specificity and lack of cross-reaction. These diagnostic tools are essential for timely and accurate TB management. Let's now turn to treatment strategies for tuberculosis. The standard 6-month regimen for drug-susceptible pulmonary TB consists of 2 months of rifampin, isoniazid, pyrazinamide, and ethambutol, the intensive phase, followed by 4 months of rifampin and isoniazid, the continuation phase. Your guidelines also recommend a 4-month regimen for certain patients, using isoniazid, rifapentine, pyrazinamide, and moxifloxacin, which offers equal efficacy and better adherence. For latent TB, short-course regimens like 3-HP, once-weekly isoniazid and rifapentine for 3 months, and 1-HP daily for 1 month are now preferred due to higher adherence. These evolving strategies reflect ongoing efforts to improve patient outcomes and reduce TB transmission. Finally, let's address some important complications and special scenarios in TB management. Biliary TB refers to hematogenous spread, producing countless tiny nodules throughout the lungs, a snowstorm appearance on imaging. When TB infects the vertebral bodies, it causes Pott's disease, leading to vertebral collapse and possible gibbous deformity. TB meningitis is diagnosed by CSF findings of lymphocyte pleocytosis, elevated protein, and low glucose. Drug side effects are also key. Rifampin causes orange discoloration of body fluids, isoniazid requires vitamin B6 supplementation to prevent neuropathy, pyrazinamide can trigger gout, and ethambutol may cause optic neuritis. Recognizing these complications ensures comprehensive care for TB patients.